Hi, welcome to the NEET PG Core Revision series where I'll be taking you through the most important topics in pharmacology that are asked in the NEET PG for your upcoming NEET PG exams. So let's start with the first topic, which we have pharmacokinetics. Now, the first thing here is routes of administration. Coming to the oral route. So, oral route, we know that whenever you give a drug by the oral route, the absorption occurs through small intestine and the stomach, but always because of the larger surface area of absorption, the absorption is greater in small intestine as compared to the stomach. Then the first pass metabolism is a very important factor which determines the bioavailability of the drug which is given by the oral route. So, higher the first pass metabolism, more will be the wastage of the drug and less will be the bioavailability. So, first pass metabolism decreases the bioavailability of a drug. Bioavailability of a drug. So, examples of drugs which have high first pass metabolism can be memorized by this mnemonic. Pre-systemic metabolism leads to high nitrate dose. So, pre it is propranolol, salbutamol, morphine, lidocaine, testosterone, hydrocortisone and nitrates. So, what happens when we have drugs which have high first pass metabolism? So, either we have to give a very large dose of the drug or we have to change the route of administration. So, just as we do with lidocaine, because it has so extensive first pass metabolism that it is impossible to give it by the oral route. So, we have changed the route of drug administration for lidocaine. So, what is bioavailability? What is the definition of bioavailability? So, it is the fraction of the dose of the drug which reaches the systemic circulation in the unchanged form. Unchanged form. It is denoted by the alphabet F. Okay. So, what is the formula to calculate the bioavailability? F is equal to area under curve of the oral route or by the oral route divided by area under curve by the IV route. Why IV route? Because IV route has 100% bioavailability. Okay. So, if we have to compare, so how we compare this? You see, this is a plasma concentration versus time graph. So, we take a single drug and we give it by the IV route also and we give it by the oral route also. So, let's say I have given the same drug by the IV route and it immediately enters into systemic circulation, right? So, the graph that we get is like this for the IV route. And the same drug, if I give it by the oral route, it will take time to get into the or get absorbed into the systemic circulation and then ultimately go like this. So, this is the oral route. So, what you do? You calculate the area for these graphs. So, for the oral route, so this would be the area, right? So, you calculate the area under curve here and for the IV route, so this whole would be the area that is by the IV route, right? This one. Okay. So, this you calculate the area under curve for the IV route and then you just divide oral over IV and that is how you get the fraction. And if you go on to get the answer in percentage, simply what you do is you multiply by 100. So, the answer would be now in percentage. That means 40% bioavailability, 50%, so on and so forth. So, that is how you calculate the bioavailability. So, moving on to the important next concept is the transdermal patches, and let's first discuss a question which had come in the previous years. So all the following drugs can be given by the route shown below except. So please see the exception is asked. Always read the question carefully and see what is hidden in the question. Okay, so whether it is fentanyl, rotigotine, scopolamine, atropine. So this is a patch which is shown, right? So we can make out that this is a transdermal patch. So the answer lies in if we know that what patches are available in the market. Only then we can say that which of the patch is not available. So first let's go and see what is a transdermal patch. So this is the structure of a transdermal patch here. So in the transdermal patch, you see it is just like a band-aid that you have, and it's a thick band-aid which consists of the medication inside, and then you peel off the layer and stick it to the skin wherever you require it. So this is the drug reservoir here. The drug is present inside, and there is a rate control membrane through which slowly the drug is being released, and it enters through the skin and definitely enters into the small capillaries in the skin and enters in systemic circulation. So this also route, it bypasses the liver. So it bypasses the first pass metabolism. That is very important. Another important thing to know that because the drug is released very slowly, this route cannot be used in emergencies. It is not a very emergencies. So because it doesn't give rise to peaks of the drug. So there are no immediate peaks that you achieve with this. So can't be given in emergencies. Also remember that sometimes students get confused whether this is a topical route or a local route of administration or systemic. So because the drug is entering into the systemic circulation here, so this is your systemic route of administration and not local route of administration. Remember this, okay? So this is a systemic route. All right. So what are the important examples of the drugs which are available in patches, and what are the indications for which they are used? So that is a very, very important thing to know. So first is scopolamine, other name is hyoscine. So this is used in case of motion sickness. Motion sickness. Then nicotine. Nicotine is used for smoking cessation. Nitroglycerin is for prevention of attack of angina or prophylaxis. Prevention of attack of angina. For acute attack of angina, we use sublingual route, not because this is not an emergency use, right? So, but to prevent any further attack or future attack of angina, there we can use this as a patch. Angina. Fentanyl or buprenorphine, so these are analgesics. So they can be used for chronic pain, like for example, cancer or post-op pain, chronic pain. Lidocaine, it is used for post-herpetic neuralgia. Clonidine for hypertension. Estradiol for hormone replacement therapy. Testosterone also for primary, or you can say just in hypogonadism in cases of hypogonadism. Rivastigmine, it is used for Alzheimer's disease. Rotigotine for Parkinson's disease. Selegiline for depression. Oxybutynin for overactive bladder. So if I have to go back to the question, so you know what other drug formulations available in patch form. So we can now solve this question here. Fentanyl, yes, it is available for analgesic purpose. Rotigotine for purpose of in Parkinsonism. Scopolamine for motion sickness. So the only option left with us is atropine. So atropine as such is not yet available in the form of patch. Okay. So let's move on to the next question. This was also a previous year question and very, very important concept. Which of the following parameter is used to assess the rate of absorption? Whether it is Tmax, Cmax, half-life or the area under curve. So we have just now done that area under curve actually is used to calculate the bioavailability. bioavailability that we know about, right? So here, this curve. So let's first understand a little more in detail about this, that this is a graph that is available to us, and Cmax and Tmax of formulation A is compared with Cmax and Tmax of formulation B. Okay, here. Now, can we say here that the Tmax, which is the time taken to achieve the maximum plasma concentration by A, is less as compared to the Tmax of B, right? Because Tmax achieves of B achieves it at a later area or a later point here. So it is faster. Tmax has achieved the Cmax faster. So we can say the quick, fast means the rate of absorption is faster for A as compared to B, because how fast the drug has been absorbed and it has achieved the maximum concentration. So Cmax just tells you about the maximum concentration achieved, right? So Tmax tells you about the rate of absorption. Half-life is just telling you about how much time has been taken by the drug to reduce to 50% of the plasma concentration, of its initial plasma concentration. And area under curve, this whole area, actually this tells you about the extent, how much drug has been absorbed. So the extent of absorption is determined by the area under curve. So rate of absorption is determined by the Tmax. So important is to know the difference, because it is asked extent of absorption is told by area under curve, while the rate of absorption is determined by the Tmax. Okay. So what is now the effect of pH on the absorption of a drug? So let's see here. We have two drugs. One is an acidic drug and the other is a basic drug. So let's see how the absorption and excretion can differ in each. So acidic drugs, they are, always remember, better absorbed in the same media, that is the acidic media. And basic drugs are also better absorbed in the same media, that is the basic media. So same media or medium, better absorption. Why? Because acidic drugs in acidic medium, they always remain unionized, right? Unionized. And unionized fraction and the lipid soluble fraction always is better absorbed. Okay. Now coming to the excretion part. So what happens in excretion? So because they are better absorbed in the same medium, they will be excreted out, remember, in the opposite medium. So acidic drugs are excreted in the basic media. Basic drugs are excreted also in the acidic media. It's opposite, right? Remember, if you remember this one rule, you can easily make out the second rule. You don't have to remember both the rules, just remember one rule, absorption in the same media. So excretion will be in the opposite media. That remember, right? Because, and here what is happening here basically, why is it getting excreted, not being absorbed? Because acidic drug in basic medium, they become ionized. Similarly this. So ionized fraction is never absorbed easily, it is excreted out into the through the urine. So therefore, we make use of this very important concept in managing drug poisoning. So we have two types of drugs, weakly acidic and weakly basic. Strong acid, strong basic, they do not follow this rule. But this is only meant for weak acids and weak bases. So when weakly acidic drugs like aspirin, phenobarbital, acetazolamide, phenytoin, warfarin, tricyclic antidepressants, whenever there is overdose toxicity with this, how can you remove this drug? That is when they're excreted into the urine. What you do, you make the urine, because they're acidic. So remember the rule, they will be excreted in the basic media. So you make the urine more alkaline, right? So how can you make the urine more alkaline? With the help of sodium bicarbonate. So we can give sodium bicarbonate. This is injected and the urine has become alkaline. So these drugs can be easily, so this is a treatment, easily excreted. So this is asked as a question. So what about basic drugs like morphine, atropine, diazepam, amphetamine, cocaine? So first remember, all of them will have or this is the only exception, en or am at the end. So that therefore this means that they are the basic drugs. So basic drugs, how to excrete them faster, that you make the urine more acidic, right? So how can you make the urine more acidic? So we give ammonium chloride or ascorbic acid, vitamin C, ascorbic acid. So this makes the urine more acidic and helps in the excretion. So this rule can be made use of in drug poisonings. The next important concept is volume of distribution. So what is the volume of distribution, or it is denoted by the apparent volume of distribution, because this is not the exact values that we get. So what are the factors which affect the volume of distribution? Is lipid solubility of molecular weight of a molecule of the drug. Now always remember, volume of distribution will be directly proportional to the lipid solubility, because you know that when the drug first it reaches into the systemic circulation, this is called as absorption of a drug. Now from the systemic circulation or from the blood, it now has to enter into the various tissues. This is called as distribution. So when it has to enter, it needs to cross the endothelium of the blood vessels, as well it has to cross or the the cell membrane or the cell wall, the cell layer, that is has to cross. So it is made up by the lipids are there present here also, there also. So lipid solubility is a very important factor. If the drug is more lipid soluble, it can easily cross the endothelium as well as the cell membrane. So this is important. So directly proportional. Molecular weight, if the drug is very high in molecular weight, it becomes difficult for the drug to actually pass through. So distribution might be less, or it might be a little more difficult or less as compared to drugs that have smaller molecular weight. Plasma protein binding. So plasma proteins are the proteins which are present here in the blood, right? So they are present in the blood itself. So what happens is that some drugs, they get bound to the plasma proteins while the other are free, or like some molecules of the drug, they are bound and the other molecules are free. So for example, we have given a drug, and some drugs are bound to the plasma proteins and others are lying free here. So remember, the drugs which are bound to the plasma proteins are called as bound fraction of the drug. The free one is called as a free form. So this free form can easily enter into the tissues. So free form of the drug is available for action. The bound form is not available for action. So therefore, plasma protein binding is inversely proportional to the volume of distribution. So more the drug is bound to the plasma proteins, less will it be distributed to the tissues. Then there are barriers like blood-brain barrier, blood-placental barrier. So these are very strict, strong barriers, especially the blood-brain barrier is a very strong barrier. So the drugs, if it's because of this, they cannot cross into the central nervous system. All the drugs, they don't manage to cross in central nervous system. The distribution would be less there. While blood-placental barrier means from the mother to the fetus, this is not a very stringent or a tight barrier. So many drugs can pass from the mother to the fetus. Therefore, we restrict the use of drugs during pregnancy. Tissue storage of the drugs. So many drugs we have, there are certain drugs that are very high volume of distribution, right? In thousands. So that means that the drug has gone and gotten stored somewhere in the tissues. Okay. Now certain diseases also, they influence the volume of distribution. So let's see them and see what are the important facts that you need to know about each of these points. So drugs with very high apparent volume of distribution. What can you say about these drugs? For example, I'll give you an example of a drug called as chloroquine, which has volume of distribution in thousands, so around like more than like 13,000 liters. So how do we explain this? Because we don't have that much of fluid in the body. So how do we explain so much of volume of distribution? So that means that this drug goes and gets stored in the various tissues, right? It gets stored in the liver and gets stored in the eye. So therefore, long-term use of this drug can lead to a side effect or an adverse effect, which is called as a bullseye retinopathy because of this. Bullseye retinopathy. Dialysis. Now, drugs which have very high volume of distribution, that means if you see here that these drugs, because dialysis is carried out in the blood, right? but the drugs which have very high volume of distribution, they are stored here in the tissues. They are no longer in the blood. So how will we remove the drug by dialysis? So drugs which have high volume of distribution, very high or high volume of distribution, cannot be removed by dialysis. That is number one. Second factor is the drugs which are highly plasma protein bound also. Plasma protein bound. They are also difficult to remove by dialysis. So they are also difficult to remove by dialysis. Why? Because they become a big molecule. So when they combine with the plasma protein like this, as compared to the single molecules, this is a big molecule. It is very difficult to remove such drugs by hemodialysis. So drugs have very high volume distribution which are not present only in the blood. They can't be removed by dialysis. While drugs which have high plasma protein bound also, they cannot be removed by dialysis. Now diseases. Certain liver diseases and in nephrotic syndrome, what happens? There is decrease in a plasma protein called as albumin. So albumin is a plasma protein which usually binds the acidic drugs, and alpha-1 glycoprotein binds the basic drugs here. So albumin is decreased. So when the plasma protein is decreased, that means the free form will increase. So there is increase in the free form of the drug, more free form of the drug. And when there is more free form of the drug, so that leads to toxicity, because free form is the one which is available for action or toxicity, that is the free form. While in the other diseases like myocardial infarction, inflammation, there is increase in the alpha-1 acid glycoprotein. When there is an increase in the plasma protein, that means there will be increase in the bound form of the drug. So when the bound form is more, that means the free form is less, so less effectiveness of the drug. So there will be decrease in the effect of the drug, right? Displacement reactions, for example, the drugs are highly plasma protein bound. So there are two drugs which are highly plasma protein bound. They bound to the similar plasma proteins. So warfarin is a drug which is 99% plasma protein bound, right? So if you give another drug like salicylates, which are also plasma protein bound, they can displace warfarin. So initially only 1% was free. So when they displace warfarin, let's say, then 2% becomes free after displacement. So what has happened? There is double the effect of warfarin, double warfarin effect. So more of warfarin effect, which is anticoagulant effect, will double. So patient can have bleeding tendencies here. Sulfonamides can displace bilirubin in neonates. So what happens? This bilirubin will go and it will enter into the central nervous system, brain of the baby, and it can lead to a dangerous condition called as kernicterus. So therefore, sulfonamides are not recommended in neonates. It can cause kernicterus. Alright. So let's do some examples of the drugs which are not removed by dialysis or where the dialysis is not effective. So remember, in mnemonic, avoid dialysis. Avoid dialysis. So this means amphetamines, verapamil, opioids. Then we cannot give, imipramine, digoxin, and dialysis D stands for diazepam or other benzodiazepines, right? While dialysis can be done in MLAT, right? MLAT, which is methanol, right? It can be done for lithium overdose. It can be done for aspirin or alcohol overdose, and it can be done even in theophylline toxicity. So remember, the dialysis is not effective in avoid dialysis mnemonic, and dialysis is done in MLAT. So overall, what I want to make you understand or remember one fact is that apparent volume of distribution, always remember, is directly proportional to the lipid solubility. Always remember, but it is always inversely proportional to the plasma concentration, right, or plasma protein binding. Plasma concentration of the drug more, that means the drug is there in the plasma only, it has not entered into the tissue. So, it is there in the hemodynamic, in the systemic circulation only. While if the plasma concentration is less, that means the drug has gotten away or moved away from the blood into the various tissues and it has distributed. So, similarly, distribution would be high only if the drug is less in the blood and more into the tissues. Okay. So, moving on to the next concept, a female patient who's on oral contraceptive pills has been diagnosed with tuberculosis and started on the anti-tubercular therapy. She was advised to use an additional barrier method of contraception. What is the rationale behind this? Now, whether it is OCPs have teratogenic effects, ATT may become ineffective, rifampicin reduces the metabolism of OCPs, or rifampicin enhances the OCP metabolism leading to contraceptive failure. Now, here comes an important concept for us, the CYP or the metabolism that we should be knowing. So, let's do what it is. Now, cytochrome P450 enzymes are important enzymes responsible for metabolism of the phase 1 reactions mainly. So, you know that the metabolism occurs in the liver and there are two phases, phase 1 reaction and there is another phase 2 reaction. So, phase 1 reaction is mainly done by the cytochrome P450 enzymes. Phase 2 reactions is by the glucuronide transferase enzymes. So, the most common phase 1 reaction is oxidation and the most common phase 2 reaction will be glucuronidation. Alright, so moving on to this, which is the important, this cytochrome P450. The nomenclature, cytochrome P, this is the CYP, what is the other 3A4? So there are different enzymes. So one example I am taking is cytochrome P3A4. What does this mean? So 3 means the family of the enzyme, A stands for the subfamily, 4 stands for the genes, exact the gene locus or the gene area. So that's why C3A4, that is the rule here. Now we have certain substrates for these cytochrome enzymes. There are few substrates that are important for you to remember for the examination point of view. They are asked. So first is the CYP3A4 substrates. Remember the mnemonic CT scan. Now these are important to know because many times questions are asked on this, that what is the important substrate for this and metabolite, which is the important metabolite, or substrate inducers and inhibitors. So all sorts of questions are there. So let's do only the important ones. CT scan is the mnemonic. C stand for CCBs. Then we have the estemizole, then tacrolimus, then we have terfenadine, statins, cisapride, amiodarone, and navids, the protease inhibitors. Remember, CYP3A4, it is very important isoenzyme because it is responsible for carrying out 50% of the metabolic reactions in the body. That's why it is one of the most important enzymes. Then we have CYP2C19. So remember mnemonic OCD, omeprazole, clopidogrel and diazepam. So here one of the very important questions it is asked here. So clopidogrel is an antiplatelet drug. Clopidogrel is an antiplatelet drug and is given in cases of myocardial infarctions to the patient. But this is a prodrug and it gets activated in the body with the help of this enzyme CYP2C19 and it gets activated. Right. So it is necessary, otherwise the action will not be produced. But if we give it with another drug, which is a proton pump inhibitor, that is omeprazole. So omeprazole, it also inhibits this enzyme, CYP2C19. So when you give omeprazole with this, clopidogrel is not going to get activated and therefore it is not going to produce the response. There will be failure of therapy or antiplatelet action by clopidogrel. So this is a very important drug interactions. that patients who are on clopidogrel, they should not be prescribed omeprazole. Then we have CYP2 D6, and here you can remember two Ds. One is DIL and the other is the mark. So drug, DIL means heart, the mark means brain, right? So the drugs which are used in heart and the brain. So tricyclic antidepressants, or they are all the SSRIs, etc. They are there, and the heart drugs like antiarrhythmics, beta blockers. But antiarrhythmics except amiodarone, because amiodarone we did in CYP3A4, except amiodarone. Okay. Then we have CYP2C9. So war at 9, remember warfarin. So there is war at 9 p.m. Remember warfarin, very important example. Then CYP2E1. E1 means everyone. Everyone uses paracetamol. So paracetamol is a very important substrate for CYP2E1 that you have to know. Then moving on to the other important examples which are of the enzyme inducers and enzyme inhibitors. Enzyme inducers, remember a mnemonic GPRS cell phone. That is griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and another one you can remember with C is chronic alcohol intake and phenobarbital. Right? So these are the enzyme inducers. So whenever you give it with any other drug, they will increase the metabolism of the other drug. So for example, you use phenytoin with OCPs, oral contraceptive, or you use rifampicin with OCPs, oral contraceptives. What is going to happen is, if the female was taking an oral contraceptive without any of these drugs, so let's say that gets metabolized in 24 hours. So the patient takes one dose today, and after 24 hours the next day she will take another dose of oral contraceptive pills, because she knows that she's been protected for 24 hours. But when she is on another drug, another inducer like rifampicin, she develops tuberculosis, was prescribed rifampicin. So rifampicin is a enzyme inducer. It increases the metabolism of this particular OCP, and it will make it so fast that this OCP now it gets metabolized within 12 hours only. The rest 12 hours, the patient is unprotected, right? And so patient can get pregnant even while being on an OCP. So that leads to OCP failure. So what we prescribe or tell the patient that either you should use some other method of contraception, because alone OCPs will not be sufficient. So any inducer when you use with any other drug, and if the question comes there is a failure of therapy, so just make sure that you know this list, because this list is a very important list of drugs. Mostly the inducers are asked from this particular drugs only. So they are increasing or enhancing the metabolism of the other drug and causing failure of the therapy. While on the other hand, we have the other groups which are called as enzyme inhibitors. So another mnemonic to remember, pro alcohol in coke. So this is pro means pro, valproate, right? Acute intake of alcohol. Chronic was inducer, acute intake is inhibition. Isoniazid. So exceptions are like most of the anti-epileptics are usually enzyme inducers. The exception being valproate. Most of anti-TB drugs are enzyme inducers, exception being INH. C is for cimeridine, ciprofloxacin, O omeprazole, K ketoconazole, and E is erythromycin. So if you get an example, especially with these drugs, we get antifungal drug or this drug, what you get is you are giving, let's say, ketoconazole, or you have given erythromycin with a drug which is, let's say, theophylline, and patient develops excessive toxicity with theophylline. So what is the reason? This is an enzyme inhibitor. It will decrease the metabolism. So theophylline, for example, again, it was first, let's say, getting metabolized in, let's say, about, again, I'll take hypothetical, 24 hours. So let's say I was giving 50 milligrams of theophylline 24 hours ke baad, again because it gets metabolized. So I will repeat 50 milligrams of theophylline here. But when you're giving erythromycin, because it is delaying the metabolism, so now theophylline may be getting completely metabolized. In 24 hours only 25 is getting metabolized. Another 24 hours may 25 is getting metabolized. So ideally At the end of 24 hours, 25 is still left. And if you don't have the knowledge, you're again giving 50 milligrams of the drug. So ultimately, how much drug we have? Here is 75, right? So what is happening here basically? There is already a drug present. Again, you're giving more drug, so it is increasing the toxicity of the drug. So toxic signs and symptoms will appear. So when a drug, another drug is being given with enzyme inhibitor, you need to decrease the dose of the drug. But with an inducer, you will have to increase the dose of the drug. This fundamental rule you should remember. So with this knowledge in our backhand or in back of the mind, now let's go back to the question which was asked here. So a female patient who's on oral contraceptive, right? So we did this example. She was started on anti-tubercular therapy. So what is the rationale behind this therapy? Basically, so most probably in the anti-tubercular therapy, because those are mostly enzyme inducers, they are talking about rifampicin. This is the action. So rifampicin, it enhances the metabolism of OCP and leads to contraceptive failure. It doesn't reduce the metabolism, right? It enhances the metabolism. So the OCP is metabolized faster and they cause failure of the therapy with this particular drug. Okay. Next we come to another important short topic, which are the different drugs which are metabolized by plasma esterase. So we have done cytochrome P450. Now there are certain drugs which get metabolized in the blood, in the plasma itself. And such drugs, they are very short acting drugs. They act quickly also. They have a very short half-life, short duration of action. So the important ones are procaine or cocaine, esmolol, remifentanil, remimazolam, nevacurium, succinylcholine. So all these drugs, they get metabolized by the plasma esterases. Therefore, they have a very, very short half-life. Another important concept is P-glycoprotein, which is also a very commonly asked question. So P-glycoprotein efflux mechanism, usually we say. There are other names. We have MDR, multi-drug resistance 1 pumps, same, or ATP binding cassettes or ABC. So they are similar. So they're asked like what are the substrates? Now the substrates are also these are inhibitors. Digoxin, erythromycin, clarithromycin, verapamil, quinidine. And then we have inducers. Inducers, rifampicin, phenytoin, carbamazepine. So you'll see, just to give you a hint, is like the CYP inducers are also P-glycoprotein inducers, and the inhibitors over there are also similar. They are the P-glycoprotein inhibitors. So many a time the question has been asked on verapamil, then there is digoxin also involved, then quinidine. So inducers is easily to you can remember because they are similar. These are also the inducers for CYP. They're also the inducers for the P-glycoprotein. Now, what is important here? Let's see about the P-glycoproteins. So this P-glycoprotein efflux mechanism, this is important in certain areas like intestine, blood-brain barrier, liver, and kidneys. Right? So they are efflux pumps. As I told you, these are efflux pumps. So they will throw the drug outside. So like suppose here they are present and this is the cell here. So when the drug enters inside, so the efflux pump is going to throw, this P is going to throw the drug outside. Right? So this is the role of the efflux pump. So similar in the kidneys also it will be the same, in the intestine also it will be the same. So any drug which is going to inhibit this, for example, I have a drug and I am going to inhibit this pump. So what will happen? The drug will not be effluxed out. So many a times it can lead to toxicity of the drug. Inside the drug is there, so it can enhance the toxicity. So these efflux pump, if you give inhibitors, it can lead to increase in the drug toxicity. So there can be an example, for example, the inhibitor, let's say erythromycin with digoxin. So it can inhibit the efflux pump. So there can be enhanced toxicity of digoxin, increased digoxin toxicity. So the question can be asked, what is the reason? Because it is a P-glycoprotein inhibitor. The efflux pump is working, so that can be there. Well, this is also responsible for causing resistance in certain anti-cancer drugs, because what will happen because of the pumps is that drug is no longer concentrated in the cell itself. It will be again thrown out of the cell. So it can be a cause of the resistance of this multi-drug resistance in cancer. That can be another, you can say, the point for P-glycoprotein. Moving on to the next concept, this is the plasma half-life. So what is plasma half-life? It is a time duration in which the plasma concentration of a drug is reduced to half of its original value, right? That is very important. 50% of its original value. The formula is important. T half is equal to 0.693 into volume of distribution divided by clearance. And it helps you decide about the dosing frequency of the drug, right? So that is important. Now, the thing is that plasma half-life, another important concept you should know, it takes 4 to 5 half-lives for the drug to reach its steady state or plateau or steady state concentration, which is usually the therapeutic concentration, steady state concentration. While similar half-lives are required by a drug to be eliminated. 97%. So 97% elimination of a drug is almost done in about 4 to 5 half-lives. So let's see with the help of an example. So we have a drug, let's say there is 100 milligram, 100% of the drug, let's say, and half-life is 1 hour. So every half-life, 50% of the drug is being eliminated. So in first half-life, it is 50% of the drug is being eliminated. And here I am going to say what is the remaining amount of drug, let's say here, and also we will see how much drug is eliminated. So we will make two comparisons, right? So here let's say remaining drug after every 1 hour, let's say 1 hour, which is a half-life, is 50%. So we can say out of 100, 50% of the drug is eliminated. Next, remaining is 25%. So how much drug is now gone out of this 25%? So total is 25 plus previous 50, 75% of the drug is eliminated. This is first half-life, second half-life. Third half-life, out of 12, it is 12.5. So how much has now gone? 75 plus 12.5, it is 87.5%. In the fourth half-life, half of it, 6.25. So here it is 93.75. Fifth half-life, 3.125%. So this is almost 96.8%, which is 97%. Okay, 97%. So in 4 to 5 half-lives, 97% of the drug has been eliminated. So this is what I'm trying to prove here. So in 4 to 5 half-lives, 97% of the drug gets eliminated. Next is order of kinetics. Like in the order of kinetics, first order versus zero order kinetics. First order kinetics, what is the difference? Here a constant fraction or a percentage of the drug is eliminated per unit time. In zero order kinetics, a constant amount of the drug is eliminated per unit time. That means here 50% of the drug is lost per or eliminated per unit time, and here a constant amount, let's say 50 milligrams of the drug, not percentage, 50 milligrams of the drug. Rate of elimination is directly proportional to the plasma concentration. So more the plasma concentration, more will be the rate of elimination, because 50% of that concentration is going to be eliminated. Let's say if it is 200, then 100 will be eliminated. If it is 100 milligrams, then only 50 will be eliminated. So more the plasma concentration, more will be the elimination. But that is not the case with zero order. The rate of elimination is independent. It stays constant. Whatever dose you give, it is only going to eliminate 50 milligrams per half-life, or let's say 1 hour if it's a half-life. So clearance here, it is at a constant rate, the clearance is there. Now the clearance is variable. So you will see with the help of an example, more is the plasma concentration, less will be the clearance, it's variable basically. And less would be the plasma concentration, then the clearance would be more. Half-life is constant. Here half-life is variable. So first order and zero order, it will be opposite. If it is constant, if one parameter is constant for first order, it will definitely not be there for the other. It will be variable in the other. If it is constant for zero order, it will be variable in the first order. So remember that. Plasma concentration will be doubled if the dose is doubled, but here there is a disproportionate increase in the plasma concentration. So first order is a good kinetics followed by almost all the drugs. So we don't have to remember the general rules, but we also always should remember the exceptions to the rule. So zero order kinetics is followed by a very few drugs. So zero order kinetics is followed by drugs like 0 watt power, you can remember. So 0 means zero order kinetics. W stands for warfarin. A stands for alcohol, right? T stands for tall butamide and theophylline. P stands for phenytoin. So these are the drugs which follow the zero order kinetics. So see here, let's take an example and understand. If I have 100 milligrams of a drug here, so 50% is going to be limited in every half-life. So let's say half-life is 1 hour. So after 100, it is going to be 50, 50% 25, 50% 12.5, 50% 6.25 and so on. But if I talk about the zero order kinetics, what is happening here? 100 milligrams, 1 hour ke baad almost only 50, because 50 milligram constant amount, and another 1 hour it is going to be 0. Now what if I increase the dose of a drug? Let's say I've increased the dose of a drug here to 200. Again after 1 hour, 50% is going to be out. So it is going to be this much. Again another hour 50, and then it continues in a similar manner. So see here, half-life was how much? 1 hour. And what is the half-life here? Same, 1 hour, constant. But what happens if I increase the plasma concentration to 200 here? A constant amount is going to be eliminated. So in 1 hour, it is going to be 150. Another hour, it is going to be 100. Then it is going to be 50, and then it's going to be 0. So let's see the half-life here. 200, half of 200 is 100. How much time did it take for the level to go from 200 to 100? 1 plus 1, it is 2 hours. So half-life is not constant. So this is the difference between first order and zero order kinetics. So as you go and increase, so think of it, there's a club and there's a bouncer standing outside the gate of the club. If it's first order, there are two clubs. So one is first order, the other is zero order. In the first order club, the bouncer says that if there are 100 people inside, I will let out 50% in 1 hour. If there are 200 people inside, I will still let out 50%. So therefore, there is no, you can say, no chaos in the club and no over jam packing in the club. While in the other club, the bouncer says, I will let out only 50 people, even if there are 100, even if there are 200, even if there are 400. So let's say there are 100 people, he lets out 50, so there are 50 inside. There are 200, he will let out only 50 people in the 1 hour. So there are now how much? 150 inside. If there are 400, he will again let out only 50 people outside, and there are now 350 inside. So he'll jam the club will be packed with people. So that is so it will be, you can say, the saturated inside. So that is the concept of saturation kinetics in the zero order as compared to first order, which is it is percentage driven basically. All right. So the next MCQ which we had from the previous year, which of the following formulas is used to determine the dosing rate of the drug? So remember, what is dosing rate? Dosing rate, it means the maintenance dose. Maintenance dose. So whether it is clearance divided by the plasma concentration, clearance multiplied by the plasma concentration, clearance multiplied by the loading dose, or clearance divided by the loading. So remember the formula for the maintenance dose is equal to clearance into the plasma concentration. So these are very, very important formulas. So let's see what are the various important formulas for us. First important formula is volume of distribution. If case there's a numerical given, that is the amount of drug multiplied by bioavailability and divided by the plasma concentration. Half-life is 0.693 multiplied by volume of distribution divided by clearance, or it is 0.693 divided by elimination constant. Clearance is rate of elimination divided by the plasma concentration. Most important is the difference between these two, which is asked loading dose versus maintenance dose. Now, everything is the same in the formula except for this and this. They both have plasma concentration in the numerator and bioavailability in the denominator. The only difference is if it's a loading dose, it is multiplied by volume of distribution. If it's a maintenance dose, it is multiplied by the clearance. Right? Remember, this is the only difference. So, loading dose depends on the volume of distribution. Maintenance dose depends on the clearance. So, remember, loading dose has D in the spelling, right? So, D in the spelling, and volume of distribution also has D in the spelling. So, DD, volume of distribution, loading dose. All right. So, next is another MCQ. As a medical practitioner in India, what is the correct way to prescribe the alprazolam to a patient? So, the good prescription or ideal prescription guidelines that you have to follow. So, you have to see that whether it is 1 milligram OD before bedtime for 7 days, half milligram HS for 7 days, 0.5 milligrams BD for 7 days, or 0.5 milligram daily before bedtime for 7 days. So, first let's see the guidelines for prescription. So, one important thing, we should use generic names whenever possible. Avoid abbreviations because patients don't understand abbreviations. Clearly mention the dose, frequency, duration, legibility, check for instructions, and unnecessary polypharmacy. So, out of these rules, if you see here, the in thing here I can see in first three options is there is a use of abbreviation. OD once daily, HS before bedtime, BD that is twice daily. So patients don't understand. So the best way to prescribe is give clear instructions in the simple elaborate form. 0.5 milligrams daily before bedtime for 7 days, right? So the patient, we can also write tablet. Let's say the full form is written, then you can write tablet alprazolam. So it is said that generic, yes, but also write in all caps because with all caps, it is difficult to make any mistake. So when you write in running hand, sometimes it is not comprehensible. It's very not legible. So we can write tablet alprazolam and 0.5 milligrams daily before bedtime for 7 days. That's the ideal way to write a prescription. All right. So thank you so much. We finished the pharmacokinetics here.